talk about this as we go. I am here, or I was asked to talk about the work that we're doing on fertility, fecundity, and infant health in the context of the pandemic. And everything I'm going to talk about today is joint work with Florencia Torque at Stanford, who I think some of you know, as well as a larger team of folks who we've been working with. And so in the context of doing all of this, a feature that has been really nice is the opportunity to work closely with people who are in maternal and fetal medicine, in pediatrics and epidemiology. And several pieces of this work have now extended into a very applied form of demography, which is different than I have done a lot in the past. And so we've been partnering with state public health agencies to potentially put forward some applied work to support people in pregnancy. So I'm happy to talk about that in the Q&A. Okay, so why study fertility in the context of something like COVID? Like, is that really what we should be focusing our energy on? And I think you're going to have an opportunity later today to talk a little bit about how the demographic community has responded to the pandemic and where we've done well and where we haven't. I would say that our motivation for getting engaged in pregnancy in the context of this pandemic is multifold. So, a key part for me and for the work that I've done over the last few years is the idea that when we have a source of stress, of major system level stress, from a sociological perspective, this presents a very unusual opportunity to learn about social distributions, about social systems, right? We can learn about a system by introducing stress into that system. Secondly, and at a more micro level, we can learn about human behavior by observing it in the context that changes rapidly around people, particularly when that involves interrupted features of social organization and social function. These are very old ideas in sociology, but they're relevant for the study of demographic behavior in the context of large-scale events like this pandemic. And so for me, for fertility specifically, it's an opportunity to ask and learn, gain new insight about why people have children, how and why people time fertility in a specific way. And fertility timing is in many ways very hard to study in day-to-day usual circumstances. And so in the context of events like this, it gives us an opportunity to learn about that. Who adjusts their timing under what circumstances, and what does that show us about the context in which people are having children? From a demographic perspective, a much more macro perspective, then we have the opportunity to learn about how populations are built and rebuilt in the aftermath of mortality crises. And that's really important when we have large-scale shocks. COVID is somewhat different, right? In that mortality is really clustered at the oldest ages, and to the extent to which family rebuilding is very different from the kind of disasters I've worked in the past. The Andaman Sumatra earthquake and tsunami in Aceh, Indonesia, that killed several 100,000 people in a matter of minutes, in which families and communities had to be rebuilt, as well as the Zika epidemic, in which fetuses and infants risked increased mortality risk because of the infection epidemic. So COVID is distinct in that the mortality crisis we're suffering here doesn't have the same obvious implications for family rebuilding. We can talk a little bit more about that. Nevertheless, the next generation of people is, of course, being gestated and delivered and considered in the context of this pandemic. And so thinking about fertility there is very important. Sometimes crises and large-scale shocks like these present an opportunity to differentiate biological and behavioral mechanisms. And in the demographic study of fertility, this is really important, right? Like, how do we differentiate between the things that shape whether or not people are able to conceive and carry a pregnancy to term, and the decisions people make to engage in family building?
Jenna, can I interrupt for 1 second? Sorry.
Please.
Are you switching slides?
I am. Can you not see them?
No, I think we're seeing just your title slide.
I wonder why that is.
Oh, probably because you're sharing screen of the unpresented PowerPoint app, but not the presented version of it.
Okay, so after doing this for 2.5 years, I have not encountered this specific problem yet. Okay, how about?
I think you need to share all your computer. Otherwise, as Shinge said, you are only sharing like your actual PowerPoint and not the current presentation. So I think the easiest way to go is share everything.
Let's try one other idea. Okay. How's this?
Can you maybe flip forward? Yep, it's changing now.
Awesome. Okay. My apologies. Some of that probably didn't make sense. Okay. Disaster is window into human behavior. Fertility specifically, rebuilding populations, differentiating biological and behavioral mechanisms. Brilliant. Okay.
I thought your text was so clear, Jenna, that I didn't even miss the slides. It was super,
thank you,
great. Yeah.
Okay. A second motivation is that appropriately in the immediate onset of the COVID crisis, a lot of attention is focused at the older ages, right? And that's relevant. I should have put a source here. I think this is a Josh paper actually. At the same time, there was a fair amount of divestment away from maternal and child health programs, particularly at the state level. And so I've learned a lot about working with a couple of state programs that was surprising. A recent paper looked at NIH allocations, 3.6 billion in 2020, less than 1% goes to maternal health, COVID-related funding, less than 3% to pediatrics. Okay. Perhaps not surprisingly, the pandemic did have implications for pregnancy health, for infant health, and for maternal health. And whether or not this is causal or this was a pathway, this is something that was already underway in the context of the pandemic is still TBD. But these are non-trivial increases in Black and Hispanic maternal mortality that took place. A lot of our work that I'm not going to talk about today suggests there are real implications for things like preterm birth, NICU admission, assisted ventilation, things that are serious health implications of pregnancy and delivery in the context of the pandemic. Okay. A different reason that we really care about this is that exposures in utero and early childhood have enduring effects on health and welfare, right? And so thinking about the health inputs that are taking place in the context of the people who are getting pregnant and giving birth has implications for the next generation of people who will now grow up. And in some ways, to the extent that this is something that generates inequality in birth outcomes, this can be one of the most enduring mechanisms of inequality produced by the pandemic, is how it shapes the health of the next generation of individuals. To do that work well, we have to know how population composition is changing. And as a very brief point on this, I'm sure some of you know about this paper, but there's a paper forthcoming in the Journal of Political Economy that does a really interesting job of demonstrating that the things that we thought we knew about the implications of the 1918 flu pandemic on the long run health of the cohorts born during that pandemic may actually be, well, appear to actually be entirely explained by changes in who was giving birth in 1919 versus any infection or other dimension of the 1918 pandemic on the health of that cohort. Okay, so to do the work well on health implications, we also have to know who's being born, and that fundamentally is a product of who is giving birth and changes in fertility. So today, because this is a methods week, I'm going to talk a little bit about fertility specifically using birth record data from California. In our larger project, we have data from New Jersey, Florida, Wisconsin, and Alabama, but I'll just tell you about California today. And then I'll tell you what we're doing about fecundity. And this work isn't done yet because there's, as you'll see, there's so much that has to be done to verify things as we go. So I don't have estimates for you to leave with on fecundity, but I'm going to tell you about the study design so you can think about it. We can talk about it. Okay, so California, for those of you out there, completely unremarkable. This is a huge state in the US. This is 12% of all US births, incredibly diverse, larger than many countries combined in Northern Europe. So certainly worthy of our attention when we think about what's happening in the context of the pandemic. The response in California was early. The shelter in place began on March 19th. The case spike is in January 2021, so a little bit later than other parts of the country. There's a second spike again in 2022. And that's something that we don't know much about yet. So what we did is we partnered with the Department of Public Health there and have early access to birth certificates. And birth certificates are arguably the best resource to study fertility, or at least to study birth counts, because these have established validity from validity studies on key markers that we care about, like parental sociodemographic. Birth certificates are not an end-all be-all data form. You know, there are many things on the birth certificate that are not particularly reliable. These we think are really quite good. Most importantly, this has more than 99% of births in the state of California. I mean, it's nearly complete coverage. And from the perspective of trying to understand population subgroup variation, the role of inequality, we need everyone. And so birth certificates are really important from that perspective. Okay, when we think about what we might predict in the context of the pandemic, you know, you've probably heard and thought about these already, but I'll run through some of these arguments, which is fertility and macroeconomic cycles tend to be pro-cyclical. And so to the extent that there's a large economic crash that's coming in April of 2020, we worry about what that means for fertility decline. Concerns about safety may have led to fertility delay. Assisted reproductive technology, so IVF, IUI, this closed entirely in March and April 2020. And some clinics are closed even longer than that. And then unemployment, illness, and caregiving stress may have made it harder to conceive and to carry pregnancies to term. At the same time, the US is amidst 10 years of fertility decline when the pandemic begins, right? So there's this pretty significant year-to-year period TFR decline that largely reflects, or we think reflects, fertility delay. So when we think about what's changing with fertility, there's a demographic shift that's happening in the background that we have to be aware of. Abortion and contraceptive access were disrupted, but I will say this is much less so in California than in other states. So for those of you who study abortion and reproductive health know that abortion was classified as an elective procedure in several states in the aftermath of the pandemic. And we see big reductions in abortion access, for example, in Texas during this time. Each of these processes has implications that may vary by background characteristics like education. So you've got pressure, downward pressure on fertility, potential upward pressure on fertility if delay is trying to be recouped, stratified pressure by things like education, income, race, location. So most demographers initially had predicted that the effects or the pressure, the downward pressure would trump the upward pressure and that we'd see fertility declines. And this led to, you know, a lot of media attention around the coming pandemic baby bust. I'm sure many of you heard this. So part of, you know, our task here is to learn when that happened, whether that happened, how long that happened for. Here are birth counts in California by year and month. March 2020 is this red line right here. And you know, here's a line fitted to the series. You know, don't overinterpret this too much because of course there's huge seasonality in births throughout the year, right? July, August births are 20% larger than January, February births in any given year. And so this is really just picking up the seasonality of this last year here. But there does appear to be some sort of slowdown in this long run decline. Now, to think about what kind of fertility response can we attribute to the pandemic, we really need this difficult counterfactual, which is what would have happened to population fertility had COVID-19 and everything else bundled along with it not occurred. To do so, we really need to predict the counterfactual. And I want to pause here to walk through a couple of different approaches that people use to do this, because this is really the crux of the methodological piece here is we're going to try to detect deviation from something that we think might have happened had this not occurred. And that requires a fair amount of assumptions. And this is where we can use both data-driven approaches, but really theory-driven approaches are pretty important. So commonly, what we would do is we would try to find a population that is unexposed, right? So in the context of large scale crises, mortality shocks, economic shocks, epidemics, we might have information on places that are not exposed, and we can use what happens over the same time period to leverage that period change to apply it to places that were exposed and use that to generate a predicted set of values. There are several different ways to do this that are increasingly fancy or not fancy. Most commonly, this is referred to as a difference in difference approach. I think all of you are familiar with this. I've put a little link here. I'll send these slides around to Aisha so you can have them, but I've put a link here to a Scott Cunningham intro that I think is actually a very useful and nice intro to D&D methods. And for those of you who have a econometric background, you're well aware of the absolute explosion in new information around the D&D approach. And so this is all to say, this is a field that is methodologically evolving very quickly. And I have found Scott to be very helpful in translating that information to a wide audience. Okay, another approach you could use, oh, sorry, here's an example. This is the tsunami hits in December 2004. Here is age-specific fertility rates here in red in the pre-tsunami period. Here it is in the post-tsunami period. These are places that had tsunami level mortality. These are places that did not have tsunami mortality, right here in the blue. And it's this difference minus this difference gives us the TFR difference that we find. And then because, we can look at this across age specific rates, we see really where this is happening in people's reproductive life forces. Okay, so that's a D&D approach. We could also use a synthetic cohort approach. And just out of curiosity, so for those of you in the room, because I can see the room, is this something you've talked about in classes before, you're familiar with? Not really, okay. The logic here is that this is both, this partners a data-driven and a theory-driven approach to generate a counterfactual. And here what you're doing is, it's totally fascinating, is you're, you select a bunch of places that you think are appropriate comparisons. And so imagine you have 20 places that you think that this is the appropriate comparison for the period trend. These places will help me know how things would have changed if had some exposure not happened. And then what you do is all of those places, you assign them a weight so that their weighted sum matches the temporal pattern of fertility prior to the exposure of interest. And you use that weighting vector to then generate a prediction of the post-exposure fertility in any given given location. And so the predicted value then comes off of a data-driven approach where you choose the counterfactuals, so theory-driven, but then the weight to each of those counterfactuals contribute is data-driven, relevant to relative to your exposed location. That is a very quick summary. There's no body paper here that does a nice description that you can check out. This is what we did in the context of the Zika epidemic. So we chose other municipalities in Brazil that matched Recife, which is where the pandemic there originated, that match Recife on a bunch of other characteristics. And then we allow a weighting vector to reveal itself. And this gives us a deviation from predicted values in the aftermath of the onset of peak Zika infection and when the emergency was declared. A key here for us is that, or a key piece of the synthetic cohort approach, is that you can generate an empirical distribution of a whole bunch of placebo tests where you take every comparison municipality and you run the same experiment as if that was the exposed municipality. And then that gives you a true distribution of placebos. And so you can come up with, essentially intervals and over which you think you have achieved statistical interpretation that's useful. I will say one key thing that we did here with this Zika cohort that was important was that because the peak Zika infection hit Recife before anyone knew about it, this was an opportunity to differentiate biological and behavioral responses. And so here what's happening is max infection in there in terms of fertility change would really have to be about biological effects on conception and pregnancy termination. This, what we end up finding is reductions of fertility that take place 10 months, 9 to 10 months after the national emergency is declared. Okay, so those are two situations where we have information, we have unexposed places, right? COVID is pretty difficult because arguably no one in the US at least is unexposed to this bundled treatment, the array of things that happen in spring and summer 2020. And so, you could think about exposure that's differentiated by infection rates, for example, but when we think about this crisis, this one is much more difficult to disentangle. Like I'm going to pin down infection effects versus the economic collapse versus people's fear about what's going to happen. And so we have this thing coming forward. We need to come up with a prediction in the absence of COVID that doesn't leverage information from other places. There's a couple of ways to do this. And you can use time series analysis. This is really common in economic forecasting and has been used to study fertility and health in the context of many kinds of things like COVID. You can also use demographic forecasting. And so this may be a paper or a set of things that Josh, you've already talked about to the group that is leveraging the insight of the Lee-Carter forecasting model. Okay, so today, what I'm going to show you is based on very straightforward ARIMA models that leverage what has happened in the past to predict future fertility outcomes. And all that's happening here is paying attention to trend, to seasonality, and to other forms of period-to-period autocorrelation. And you try to fit a model as best as you can to the pre-pandemic period. Use that model to predict, to forecast forward the fertility that would have been expected, and then test for deviation from those predicted values. The key here is that we can't necessarily talk about this as the COVID impact. What we can talk about it is deviation from what we would have predicted had happened if everything had basically stayed the same in terms of temporal and period autocorrelation. If anything else is happening at the same time as COVID, that's going to be wrapped up into what we can infer in terms of the exposure. Does that make sense, the difference there? Okay, great. So I'll run through a couple of quick findings and then I'll come back to methods for a bit and we'll wrap up. This is the proportional deviation of birth counts from expected values in blue. And so this is the piece to pay attention to here. Here, this is January 2021. This is about a 5% drop in birth counts in California. Now, of course, we might worry that we have no denominator here. And, all of this prediction is making some assumptions about the exposed population. We used the monthly CPS data and estimated GFR rates and found essentially identical results. So we were, the monthly CPS is nice in that we can come up with, California reproductive age women. We even could do this by race and by education to get these denominators. So this is really not a story about people moving out. Moreover, from a theoretical perspective, the kind of net migration effects we might expect those down here, right? Not necessarily in December, for example. Okay, but what's interesting then is we're back at expected values pretty quickly into spring of 2021. So this dip is relatively short-lived, and it corresponds to in figures I haven't shown here, this corresponds to missing conceptions in March, April, and May. So the very early parts of the pandemic.
Jenna, can I just ask a technical question here?
Please, yeah.
So you're saying you're kind of forecasting forward. Let's just pretend this is a one-year forecast.
Mm-hmm.
So the first half of this graph would be based on the years previous to that, and you would stop inputting data. The forecast would be based on data through the beginning of your graph.
Yes, exactly. Sorry, these are all.
Get to the middle of the graph. Is that also based on observations only to the beginning of the graph, or does that include the previous year? In other words, are the I see. I mean, I want to see the dots as above the line on average. I know they're not, that each individual dot is not statistically significant from zero here, but on average, they're above. Is that above based on the previous year or above based on the prior 5 or 10 years before this series even, before what you're showing us even starts?
Really important point. Okay, so what we've done is the input values that these parameters are estimated off of are January 2014 through February 2020. And everything from April forward is an estimated value that's using a prediction that's predicted from prior to February 2020. And so none of the
that makes sense. That's what I thought, but just wanted to make sure that that's the kind of common sense approach. But it's so let's just say births were constant in the 5 years before that, and that our forecast would be a straight line. The dots below the line are less than that historical average, and the dots above the line at the end of the period are above that historical average. Trend, seasonality, and all that we've taken out.
Exactly. So that's like the next point here, which is that this still, and these are still values that are declining over time, but they're not different from predicted values where there is this long run decline, right? And so this is one of the things that we've had a lot of discussions back and forth with on, other people working in this field is when people just take the difference. So the difference are honestly not even people in this field, so much reporters are saying, well, fertility or births continue to decline. They continue to decline in California. I'm like, well, they were declining already. And so, yes, that's still a fascinating phenomena with implications in the way that period fertility always has implications for state and local planning. It is a deviation that is difficult to attribute to the pandemic because it matches closely what was already underway long before. Okay, one of the things, of course, that we are curious about is really, this is just a story about ART closing, So here are births supported by assisted reproductive technology, obviously falls right off in a way that's consistent with when those closures happened. If we come back here, these red lines here then are births that did not use ART. And so while ART does contribute particularly to missing births among the highest educated folks, it's 10 to 15% of the story. It is not the majority of the pandemic baby busts that we see. Okay, if we start looking at subpopulations, this becomes really interesting. So this is the same, this is late 2020, early 2021. This is really a story about older people not having births or delaying births in the onset coming pandemic. Really a story about super highly educated folks. So there are some, this is not zero, but this is much, much larger, right? Okay, this is 20% decline in the size of the birth cohort. We could look at zip codes because we have information on where people live, and we can also categorize zip code, and we again see larger declines in higher resourced areas. A key point though is that when we look amongst the most highly educated, here's differences across race and ethnic groups, and we do see some declines among Hispanic folks, certainly among non-Hispanic Asian folks, to a lesser extent non-Hispanic white folks, and very little evidence of decline among non-Hispanic Black folks in California. When we look among the most educated people, we do then see drops across all groups. So this really seems like this is a story that's about stratification by socioeconomic status. Okay, so our takeaway then is that to the extent that there's a pandemic baby bust, it's small at best, right? These ongoing declines are unlikely attributable to the pandemic alone. And instead, one way to interpret this, both because of some of the work we've done on fetal death, as well as the patterns we see here, this is much more easily to interpret as intentional fertility delays differentially available to better resourced people. And when we say differentially available, some of the studies, so for example, the Guttmacher group did a study early on about people's intentions in the context of the arrival of the pandemic, and found that more the preference to delay fertility was larger among the least resourced people. And so the fact that we see the opposite pattern here suggests that maybe many people wanted to delay fertility, and who was able to do it were people that were really highly resourced. The fact that we don't see a big rebound for the best educated folks is, indicative of maybe some foregone fertility because of the pandemic, but it's not going to be very large from a population perspective. This is an important point, though, which is that if we come back and look at education here, the baby bust and the fall 2021 rebound are not the same groups of people. So it's possible that where we're seeing above expected values of fertility in this last fall, there's disproportionately Hispanic folks, that's disproportionately lower educated people living in less resourced places. This is not necessarily some people delayed and then recouped that fertility. In fact, this seems to be two different subpopulations. So that's interesting in and of itself. And it does suggest some potential for foregone fertility here. Okay. Can I talk for 5 more minutes? Okay. Okay, so the one other piece I wanted to say is just really quickly what we're doing on fecundity, and just because this has some other interesting methodological hurdles that I'm happy to talk about in Q&A. And so birth certificates can't obviously tell us anything about people trying to get pregnant or early pregnancy loss. And to do this, we'd ideally follow multiple preconception birth cohorts. So a preconception birth cohort are typically small clinical endeavors where 200 to 500 people are recruited who are trying to get pregnant. These people are followed forward. You see some share of them get pregnant. You see some share of those people lose pregnancies, and some share of those people go on to live births, right? And so this is the idea of how we learn about fecundity. One way is to study preconception birth cohorts. It's an extremely costly endeavor. And as a result, the sample sizes that we have on these studies are tiny, right? Lauren Wise and team at BU probably has the largest preconception birth cohort now. It's several 30 to 50,000 people, and they were able to produce some interesting work on vaccination and fecundity. Come back to that. But this is all to say, one of the things that I've been leading a team to work on the last few years is to generate large-scale population level preconception birth cohorts. And to do this, we're leveraging the back-end data of apps that people use to track their periods and their pregnancies. And the logic is that if what you need is information on sex, on menstruation, on contraception, on ovulation, and on HCG tests or pregnancy tests, as well as miscarriage, all of this information is actually contained in apps that people use to track their fertility and pregnancy and track their periods. And these are very commonly used now, and I'm happy to talk more about that. So what we did is we've partnered with a company that has a suite of apps that track menstruation and track pregnancies. Several million active users. We have zip codes, periods, intercourse, contraception, ovulation, and pregnancy. And because there's a very low response burden, because people are talking to their phones, we have a fair amount of detailed information on people's lives, including a very low response burden way to ask about sex. A lot of information to characterize individuals. Critically, because we know where people are, we know quite a lot about them. Tremendous income variation in this group. This is several million people, people that live all around the US. Okay, so this is just to say that, yes, this is a non-random subset of the population in really important ways that we could talk about. And yet there's still quite a lot of both regional and socioeconomic variation in the sample. Okay, most important for us is that we can learn information about miscarriage even if people don't report it. And key here is that we can see people report home pregnancy tests and then see their menstrual cycles resume. And when we do this, we see that about 30% of positive home pregnancy tests 30% of people with positive home pregnancy tests resume menstruation within 12 weeks after that, or sorry, within 8 weeks after that positive home pregnancy test. So within the first trimester. And that's about the estimate that we would expect to see. So to use this data, we've done a tremendous amount of work to try to validate it. A lot of other things like post-stratification weighting I can talk about. Here is the probability of pregnancy termination by maternal age. This is in a Norwegian registry, using Norwegian registry data. And this is the same figure of the data that we have here. And so there are several things we've done like this where we're able to match, although there's a tremendous amount of noise in this data, there seems to be some signal, and some signal that's meaningful. So here, we're able to match a pattern in registry data, and one that is also very consistent with theoretical biological expectations about pregnancy survival rates. Okay, so what we're doing then is we're setting up, think about it as, people start using the app, people are trying to conceive. Think about this as consecutive preconception cohorts, or consecutive preconception cohorts, and then consecutive conception cohorts in the same locations. And so that allows us to use event history or time to event specifications to estimate the within place change in the monthly probability of conception among those people trying to conceive, and among pregnancy termination among those people who have reported a positive home pregnancy test. We can estimate the change in that probability before and after March 2020. And then for us, because we are interested in vaccine effects on fecundity, the rollout of vaccination that's both known and across time and place. And then, as I mentioned, we use location level post-stratification weights to weight the data towards a population group. That is an imperfect way of dealing with the sample selection here, but it does at least take the data and make it match the population of reproductive age people in the US on basic characteristics like age, race, education, features of the location, a rich array of features of the location, actually, because we have zip code data on almost everyone in the sample. Okay.
Jenna, sorry, I may have missed this, but you have conception on conditional on trying to conceive, and then termination conditional on being pregnant. Termination, do you mean abortion, or do you mean all kinds of ways of becoming? I guess I don't even know what the definition is.
No. Okay, so really important and great point here. And so one of the things, so what we're looking for is pregnancy loss, right? We're not trying to learn information about abortion from these apps. And so one of the things that we've done for all of this is we're conditioning on people who are trying to get pregnant. And we've used information from the Guttmacher Abortion Patient Survey to learn about the share of people who have an abortion who were trying to get pregnant when they got pregnant. And that's about 1 to 2% of people who are trying to have an abortion. And so for all of the estimates, we're able to, well, here, this kind of specification is something that's going to difference out anything like that that's enduring over time. But for just the general probability estimates, we've basically created bounds around them that take into account the potential role of abortion as being some small fraction of these terminations. So that's a really important point. And if we were studying the effects on fecundity among people that are not trying to get pregnant, that would be absolutely critical here. Okay.
Thank you.
There's so much that we could talk about, so I'll stop there and we can discuss.